Next, we're honored to welcome Dr. Ghanem, a board-certified expert in head and neck surgery and ENT in facial plastic surgery, a graduate of the University of Utah and trained at UVA and OHSU. Dr. Ghanem is affiliated with Premier Head and Neck Surgery in Flint, renowned for his surgical skill and patient-centered approach, earning a perfect patient satisfaction score. He also exemplifies global leadership, having led surgical missions in Kenya, Turkey, and Lebanon. Please join me in welcoming Dr. Ghanem. And his talk is on sleep apnea management.
Hi, good afternoon. Tamara Ghanem, I'm glad to be with you here. Jill, thank you very much for the invitation. Dr. Asmaro, thank you for inviting me to be part of this group. And today what I'd like to do is just share with you an alternative to CPAP. It's called Inspire therapy. So we're gonna kind of talk a little bit about that. Let's begin. This is my contact information here. If you want to scan the QR code, it will also be available at the end of the talk in case you need to reach out to me. It has all my contact information. And okay, I have one conflict of interest, but this is not going to affect my talk today. I am a advisory board member on Oxygen Incorporated. Today, what I'm wanted to do is first just lay some very fundamental background on what obstructive sleep apnea is. Since I'm going to be talking about the treatment, I figured, you know what, we're going to just talk about what obstructive sleep apnea is and try to clarify that for all of you. And then we'll talk about some of the treatments available, and we're going to obviously hone down and really go into more specifics on Inspire implant. And then we'll talk about some of the outcomes with that and take any questions, or if you're having a panel at the end for questions, write them down. So obstructive sleep apnea basically means that there's an anatomical blockage of air going into the windpipe. So, and that blockage could be in the nose, could be tonsils in the back of the throat, could be the back of the tongue, anywhere where along this axis here, along the axis here where air could be going down to get to the area of the voice box, whether it's the back of the tongue, soft palate, tonsils, anywhere along that where there's a physical blockage of air going in, that can cause obstructive sleep apnea. And what happens with it, and the reason it's dangerous, is obviously you get low blood oxygen levels, and that's not good for a lot of different organs because everything is dependent on oxygen. And so, and some people, you know, the idea of snoring and sleep apnea, that tends to be always a confusing kind of thing for patients. Obstructive sleep apnea patients typically will have some snoring with obstruction, but they also stop breathing because they can't get the air in. But not everybody that snores has obstructive sleep apnea. So that's very, very important to understand. And the only way to diagnose it is with a sleep study. So when we talk about the medical risks of having low oxygen, it basically can affect anywhere along here. And these effects are actually very, very, very significant. So increases risk of strokes,
I'm listening to
dementia,
a conference
coronary artery disease,
on my
hypertension,
tombs.
atrial fibrillation. Actually
Like
now,
different speakers or
and this is
whatever.
something just in the
But
past
also,
few
I see
years,
my face.
any patient with a newly diagnosed atrial fibrillation that goes to a
I know,
cardiologist,
yeah, what are you
cardiologist
getting
now
at?
getting a sleep study on them because there's such a high association between atrial fibrillation and obstructive sleep apnea. And actually one of the highest numbers of referrals to sleep medicine is actually cardiologists because they're seeing this is a fairly common kind of problem. Sudden death, mood disturbances, excessive daytime sleepiness, and you know, it's hard to quantitate, but the number of car accidents and other types of mishaps that can happen for patients because they have daytime somnolence is quite significant. So this is a very serious type of problem for patients. So we diagnosed, like I said earlier, diagnosed sleep apnea with something called a sleep study. And there are ways to do it. You can do it at home, depending on the sleep medicine specialist and kind of what you want. And then
You're
the
lying.
sleep lab. The sleep lab is probably the more
No,
accurate of the
I
two.
think.
And actually, currently, a lot of the insurances are really pushing for patients that want to do other therapies like Inspire to actually do a in-lab sleep study instead of a home sleep study. It's just more accurate, and there's kind of a push towards that, but it can be also done at home.
Hello.
And obstructive
Oh,
sleep apnea is
Tiny
graded
Michelob?
by a scale. It's called the apnea-hypopnea index. Apnea just is the times that a patient stops breathing. Hypopnea
Oh,
is a time that they are not
yo.
breathing as much. And so they
Shower. You want
combine
to talk
both
about
of those, and you get something called an AHI.
Ballerino?
The AHI
Big
is
Bear.
basically divided
What
0
up,
to
Big
5 is considered normal
Bear?
range. Mild sleep apnea is 5 to
Yo.
15 events.
Yo,
And
what
then
is that?
moderate to severe is 15 to
Is
30, and
it
then, sorry,
it's
moderate is
booze
15 to 30, and
or
greater
no?
than 30 is considered severe
Yummy.
sleep apnea. So
Yummy.
we see
I'm
patients
gonna add
sometimes in the
booze to it.
80s, 90s,
Yummy,
and it can
TJ.
be
Fuck,
quite,
TJ.
quite
No.
bad. And
No. Do we have
we're
more
going to
whiskey?
talk
Oh,
about
yeah, I'll
this
take
because
it.
this is going to be important, the staging of the sleep apnea, because for Inspire therapy, it's only
Good girl,
valid for,
Maya.
or FDA approved only for the moderate to severe sleep apnea patients. So that's something to kind of keep in the back of the mind. So what are the different treatments? For mild OSA cases, it can be just
You're
simply trying to
Swedish,
lose
huh?
some weight, lifestyle changes, and
Yeah.
kind of repeating and kind of following up
She's
with your
silly.
physician to see if
She likes
that
her
kind of fixes
space.
the obstructive
She
sleep
likes her
apnea.
space.
Also, another very good
Maya
device for
likes
this,
you.
something called a dental
Maya, what
appliance,
a
which
pretty
basically
girl
pulls
you
the, and
are.
I'll show you up here is the
Maya.
picture. It basically pulls the jaw forward, and some patients can tolerate it and they love it and it works great, helps with their snoring, helps with their obstructive sleep apnea. But one of the issues is if you have problems with your TMJ or jaw joint, that can put some stress on that, and it does have limitations. But it's a fairly simple, effective way of
Pardon
helping,
me.
especially in mild cases of obstructive sleep apnea. And then for moderate and severe, really the gold standard is CPAP. So CPAP stands for continuous positive airway pressure. And so what that is that obstruction that I showed you earlier in that graph. It's basically pushing air with positive pressure through the obstruction to get it down to get to the windpipe. And some patients even, like Dr. Sukkar mentioned, they actually might need even additional oxygen just to help them oxygenate if their oxygen levels
Let me see your
drop down
phone, Sarah.
dangerously low when they're sleeping with a CPAP.
Come on, phone is outside.
So when we talk about
No,
Inspire, the
no,
way it
it's not.
fits
It
in
wasn't
all
yours.
of this
It's
is
white, or
those
it's
are
got a
patients
clear
that
case,
have
and there's
moderate
no
to severe
background.
sleep apnea. So
Oh,
they're
that
in
is
this
yours.
category here, AHI of
Were you
15
on
or
like
greater,
sleep mode or something?
and have
Because
tried
I kept trying to be
CPAP
like, there's
and
literally
have
not a
failed
single identifying
CPAP for one
feature
reason or
on this
another. Some
phone that I
patients
can
have
figure out whose
allergy to
phone
the
this
different,
is. Because it
masks
was
that
just,
they
it
have.
wasn't going on, it was
Some
just
patients
black,
just
and it
don't
just said the
tolerate having
time,
anything on their
but
face
the
while they
picture wasn't
sleep.
coming
Some
up. So I was
patients are
like,
just
this is a
fidgeting and they
man's
just
phone.
kind of
Because like, who
pull
doesn't have a
on the mask.
background?
It's
This
not
is so
easy to
weird.
kind of sleep with something like this. But
But that makes
the
sense.
Inspire is not meant to be, oh, it's just a convenience. I don't like the mask in
Silly.
this. It's really for somebody who
Yeah,
cannot
no,
sleep with.
seriously. It's
So
like,
that's
imposter.
really
You're Connor trying
what
to
that therapy
watch
is for.
Bluey.
So, and like I said, the CPAP adherence, so people have done a lot of studies on this, but one study from 2012 basically looks at the adherence to CPAP, and it was about 39% at 6 months. Most people, for one reason or another, just cannot. I've had patients, have claustrophobia from the mask. I mean, it's all kinds of different things. And there are different masks. There are ones that go in the nose. There are ones that are big face masks like this. But generally, there are patients that just cannot tolerate it, but they really do need it because of their moderate to severe sleep apnea. So this is where the Inspire implant comes into play. So this was FDA approved in 2014. And it's a fairly basic concept, but it's quite powerful because what it is, let's see what happened there. What happened to our screen there? Okay, so what it is there's basically a generator here. It's basically a computer chip with a battery, and it has a sensing lead. The sensing lead gets placed between the intercostal muscles, basically the muscles between the rib, and it senses every time a patient is breathing in. That information gets to the generator, and then generator sends a little electrical signal, and it goes up to the hypoglossal nerve. That's the nerve that moves the tongue, and specifically on branches of the hypoglossal nerve that pull the tongue forward. So it's basically giving the patient a jaw thrust or moving their tongue forward, opening their airway, both soft palate as well as the base of tongue, to allow them to breathe in. And this is very powerful because in the ENT world, we did a lot of sleep apnea surgery, removing tonsils, doing UPPP, base of tongue reductions with robots and things like that. We did all of these things as a field, and none of those, I mean, the best we could do in terms of success was 50%. None of those treatments were really very good for obstructive sleep apnea. Inspire therapy has actually kind of changed the landscape, that now actually surgically we're doing something that is actually very effective for patients. And I'll show you some of this data. So this is a very exciting kind of thing. And it started in 2014. It did not really start gaining kind of more traction until about 2019. And the company is very, they put a lot of advertisement and stuff. And so people find out about it and they come inquiring about it. But basically, this is the, there's a lot of peer-reviewed, over 350 peer-reviewed journals. There is 10-year follow-up data, and the STAR trial is a publication on the initial kind of 124 patients that they did the testing on. And the device, this is the implantable. This gets implanted in the chest. This is the sensing lead, this blue one here, that goes between the muscles, between the ribs, and then the stimulating lead that goes over the to the nerve, hypoglossal nerve. And the patient has a remote control, and they get to basically turn it on before they go to sleep. It gives them usually a little bit of a delay so that they can go to sleep, and then it just starts firing. And if patient goes up to go to the bathroom or something, they can just push the button and put it on pause until they go back to sleep. And then it's usually programmed in the morning when you first kind of wake up. If you wake up at a regular time, it's usually programmed at those kinds of times. So fairly simple kind of system. So, and this is kind of a patient here. This is from Inspire. This is how they're using it. So she's going to sleep here. Oh, I don't know. I guess that video won't play for me. Okay, sorry about that. But basically what the video is showing is that she basically presses it right there. It activates the device. She goes to sleep, and then in the morning, then it wakes up. And basically what it's showing is just the pathway of how the device is firing based on the inspiration, how it's kind of opening the airway. So candidacy for the implant. The first step is you have to see if patient meets eligibility criteria. So these are the eligibility criteria. HI, that's the apnea-hypopnea index from 15 to 100. So they have to have moderate to severe obstructive sleep apnea on sleep study. The BMI, the FDA approval is up to 40, but Medicare and some of the commercial insurances now go up to 35. A lot of commercial insurances still are at like 32 BMI. So that can sometimes be a problem. Sometimes we're able to overturn a denial from insurance company because of BMI. We try to convince the insurance company, hey, it's hard for that patient to try to lose weight when they're sleepy all the time in the morning because they haven't slept all night. And so who wants to go exercise when your body's fatigued and needing sleep? And so that part, but typically you have to have a BMI around 35, 32 for most of the insurances. But I have implanted people like in the 38 BMI range. Sometimes the insurance companies will allow that. And then we have to prove that patient has tried CPAP and they have failed. So they've either returned the CPAP machine and said, okay, I can't use this, like it's great, but it's just not for me. Or they use it like less than 3 hours a night. And then the other test that we do is something called the drug-induced sleep endoscopy, abbreviated DISE, and I'll kind of show you some pictures on that. That's something that we do in the operating room. And those are the candidacy things. So the DICE or drug-induced sleep endoscopy is kind of the next step. If you meet all the eligibility criteria, we say, okay, we're going to take you to the operating room, and it's an outpatient procedure. They basically give you a little bit of sedation through an IV, and we let you kind of get to the twilight zone of sleep, not too deep. And then we put a scope through the nose and take a look which way the blockage is. If it's anterior or posterior, you're a good candidate. And then we can go on to doing the Inspire implant. And usually we schedule that 4 to 6 weeks after that test. If the collapse is mainly from the sides, then you're not considered a good candidate. The good news is about 98% of the patients pass this. I actually have pictures, a little video to show you here from happens to be 2 cases that I did yesterday that were really good examples of anterior posterior collapse and one that was a concentric collapse. So we'll start with the one that passed first. This is a good candidate for Inspire implant.
Daddy Dean's attempting the stairs. That's all right.
Collapse. So let me just show you that video. Maybe. So what you're seeing here, this is inside the nose. We're getting back to the area of the nasopharynx. Take a look at the back of the nose. So this is the back of the soft palate. This is a little uvula. This is a little punching bag of the soft palate. And you see as the patient here is sleeping, they're actually starting to snore. You can see kind of the movement is kind of front to back. And every time they're breathing in, the soft tissues is collapsing from front to back and blocking the airway going. And this is at the level of the soft palate, but same thing also can happen at the level of the base of tongue. But you see the movement is kind of front to back, and that's the collapse. So that patient is considered a good candidate, and they move on to have Inspire 4 to 6 weeks later. This other patient from yesterday, he had mainly lateral collapse. So you see this anatomy here. The anatomy is very different. Here's that little punching bag, that's the uvula, and this is the lateral side walls of the pharynx. So you can see these are basically like kissing each other. They're literally all collapsed in, and you can hear the snoring. I don't know, it's in my speaker here, but basically the patient at that point is snoring, and this is just—
Hi, beautiful. Love you so much.
Everything's collapsed. He can't get breath in. And it was so bad that the anesthesiologist saturations went down to 80%. The CRNA had to pull the jaw forward so he can get the patient to breathe because he was obstructing, and his oxygen levels are just deteriorating. Unfortunately, this is a patient we would like to help him, but Inspire is not approved for that. So it's mainly anterior posterior collapse. So this patient unfortunately has to continue using CPAP or some other kind of option, but not considered a good Inspire implant candidate. So the Inspire procedure, so what we do, so for patients that are a good candidate, we take them to surgery. Surgery is an outpatient procedure, typically less than an hour. We make a couple of incisions, one incision just kind of underneath the jaw here, and that's to access the hypoglossal nerve, and that's where we put that electrode to go over the nerve, the hypoglossal nerve. And then I lost my screen again. Are you able to get the— There we go. The other incision is in the chest, and that's where that generator and that sensing lead go inside here. These are the incisions. So through the upper incision in the neck, we go down and we find the hypoglossal nerve. And I try not to give you any kind of— this is about as gory as it gets. I'm trying to be gentle. Usually my talks are very, very invasive. So this is the best I can do. So if I make anybody sick, I apologize. But that right here is a nerve that goes to the vocal cords. It's tucked in under some tissue, so we get down to that area, and we use a electrical probe. We put actually electrodes in the tongue and the floor of mouth, and then with a little electrical stimulator, we're actually mapping out the branches of the tongue that pull the tongue forward, and selectively mapping out the ones that pull the tongue back, because what we want to stimulate the ones that pull the tongue forward so that the airway opens up, and that will help the patient. If we get the other branches, then that's not going to help. That's just going to push the tongue back, and it's going to make more obstruction. So that part of it is really crucial, is to map that nerve well and get the electrode just specifically on those branches. And this is what that electrode looks like. That's the electrode there, and it's basically wraps around those branches. And then the rest of the electrode, the part that's going to go into the chest there, we have to create a tunnel between this incision and down into the chest so we can pass that electrode down and connect it to the generator. And then in the chest, we put in that's the generator there. We put in the lead, the sensing lead between the muscles, between the ribs. And then we connect both leads, the one from the neck and then the sensing lead into the generator, and we sew the generator down underneath the skin over the pectoralis major muscle here, and we close the incisions. And the battery life is usually, say, 10 to 11 years, so usually patients will need to come back after 10 to 11 years to have that battery changed out. That's also outpatient procedure. Okay, it's just a little slow. Okay. Wow. Okay, so outcomes. So the outcomes actually are really, really positive for this. This is from the STAR trial. This was looking at the apnea-hypopnea index. So this is moderate to severe, is at a level 15. The higher you go, the worse the obstructive sleep apnea. Normal is at 5. So they were able to take patients, and these are just two different registries. This is the STAR trial data in the purple. The black is their ADHERE registry for Inspire. But basically, this was their baseline prior to the Inspire treatment. And then this is at 1 year, and this is at 5 years. So it's a very consistent type of response. They also looked at a test called the Epworth Sleepiness Scale. This is a subjective test where patients are asked about different scenarios and how likely are you to fall asleep during these scenarios. Like you're driving and you're in a red light, are you going to kind of fall asleep? You're watching TV. Can you get through watching a movie or something? So that's the kind of thing. And this is again at baseline prior to implantation. Everything above 10, so the score goes up to 24. 10 to 24 is considered abnormal. So this is where these patients were starting, and then you can see that at 1 year and 5 year they normalize. It's a very consistent kind of thing. So these outcomes are very, very encouraging. Patient satisfaction, basically over 90% of the patients are satisfied at their final visit. Patients use typically on average 5.7 hours of therapy per use per night. And I do want to talk about complications. So nothing that we do in surgery, even placing a patient on a medication, there is risks to everything. So this procedure does have risks. Probably the biggest thing that we see is some tongue weakness, and it's typically temporary. In my patient population that I've done, I probably see it about 2 to 5% of the time. And usually by the time they see the sleep medicine doctor, they're usually actually better. It usually takes a few weeks and it resolves. But in the STAR trial that's published, they mention investigation. So again, this is very new to the surgeons and things like that. Those numbers were at 18%. It's not uncommon, but all of them came back. They did not mention that there was any permanent weakness. Bleeding requiring take back in the OR. I had 1 out of 80 patients that I did have to take back to the OR to control bleeding. Removal of the device. I've had 1 patient, and this was kind of very weird. She never wanted to activate it after she got it, even though she wanted to do the Inspire implant. And she picked at the incision site here. She had a extrusion of the wire. So we wound up we're probably going to just wind up explanting it. But that surgery is not easy because we're going back in scar tissue. The nerve to the tongue is there. We have to be very, very careful not to cause any problems for her. So this is kind of a big deal, but there is some patients that do want it out. And then temporary tongue soreness or pain, based on the STAR trial, they published at 21%. That usually patients, that as they kind of use it, that usually gets better. Because of the benefit that they're getting for their sleep apnea, generally they're very happy with the device. And so this is from the Inspire, kind of their growth, number of treated patients. You can see it was FDA approved in 2014, and then we're just on an exponential curve as things have gone through. So I'd like to conclude with is obstructive sleep apnea is a serious medical problem. Most patients are treated with CPAP. There are other options now for patients besides CPAP. And one is the Inspire implant. And then just actually, I think it was last week or about the week before, there's another company called Nyxoah. They have a product called Genio, and it's also a hypoglossal nerve stimulator. It stimulates actually both nerves, but it does not have the generator in the chest. The generator actually and everything kind of sits and gets kind of attached to the patient's chin. So this is something new on the horizon too that we have now with surgeons offering this. And so this is kind of a growing kind of option for patients with obstructive sleep apnea. I want to thank you for listening to me, and we'll take any questions.